Okay, everybody, we're going to continue on with the organ failure. I emailed the first part to Jenny last week, and so, this is kind of nice clinical knowledge, but the way my notes are is a very drilled down kind of notes for the test. But, hang on, I got the microphone on backwards. So we'll keep going on. And again, I'm telling you, this Washington Manual of Critical Care is drilled down up to date and drilled down score for these topics and everything. So I don't know that this stuff that we're going to cover is very much practical clinical knowledge, but this will be kind of test question stuff, okay? So today I've got respiratory failure, I think renal failure, and liver failure to cover. So, all right, so their respiration is oxygen in, CO2 out. So there's kind of two elements to failure. One is you can't get rid of CO2, and one of them is you can't get oxygen in. And so, kind of we get more worried when somebody's desatting and all that, but hypercarbic failure is kind of an emergency that can sneak up on you, okay? You can kind of be unaware that it's happening. And, I know interns have been called to the floor to see somebody that their mental status is not what it used to be. You go up there and you get a gas and their PO2's, 60 or 70 or something like that. And that's all you've got to fix, really. You fix your CO2, they wake up. I don't know if y'all have heard this term. We used to call it CO2 narcosis. This is a drug overdose, okay? You quit breathing to the point you quit oxygenating. But the first problem is CO2. So just based on blood gas values, a PCO2 of more than 45, it's ventilatory failure, the pump, the gas in, gas out. And lungs can be absolutely normal. You just got to build up a CO2, which kind of puts your brain to sleep. Hypoxia, less than PO2 of 60, and it's an alveolar problem. Hypercapnic respiratory failure, kind of covered this. It's one of three processes. Increased CO2 production. Now, how does that happen? That happens from overfeeding. We used to get metabolic carts where they took people up to the vent. You want a respiratory quotient of 1. We don't ever do that anymore. But if you've got somebody that really has no reason to be retaining CO2, respiratory can do this for you, and maybe you need to go down on your glucose, okay? It's a consequence of overfeeding. Decreased minute ventilation, they're too sleepy, too much narcotics, whatever. They're just building up CO2. They're not breathing deep or fast enough to get it out. Or increased dead space ventilation, that's shunts and everything. And just a reminder, on your blood gas, a PCO2 increase of 10 changes the pH in the other direction, 0.08. If it's a longer kind of chronic process, it's not that dramatic of a change, and the change is only 0.03 based on the bicarb retention of the kidneys. So, acute hypercapnia, the next step to that, if you don't do something about it, is just a respiratory arrest. You've got to establish an airway somehow. Okay, so you don't want to sedate these people because the CO2 is doing that. You don't want to push them over the cliff. Okay, be careful with the oxygen. If they're a COPDer, you can take out that respiratory drive of hypoxia, and they'll just quit breathing completely. So this is a case when you can actually do BiPAP or something like that. If you can kind of help the ventilation pump with just BiPAP, that may save you an intubation, but it may be safer to intubate. So you've got to help them somehow. Okay? Hypoxia, on the other hand, you're probably going to have to intubate. BiPAP's not going to work. Hypoxic respiratory failure. This is an alveolar problem. Kind of the classic example is pulmonary edema, but also a pneumonia. The alveoli is filled with water in pulmonary edema, and pneumonia is filled with pus. Okay? There's something going on in the alveoli that the gases can't exchange there. So in general, somebody that's got hypoxic respiratory failure is going to require an intubation, not just BiPAP. You're going to use your PEEP to decrease the oxygen requirement. Ideally, that's way down in the 30%, 30s, 40s, something like that, but you try to get under 60. Protective ventilator strategies of low tidal volumes, about 6 per kilo is kind of a goal. You may even have to go lower than that if your peak pressures are too high. And obviously, if you've got to intubate, you've got to go to the ICU while the lungs are getting better. All right? So you've got minute ventilation, just your respiratory rate in and out, and you've got supplemental oxygen and PEEP to get oxygen in. These are from the Washington Manual. Thank you, Fran, for sending me in PDF. I didn't have to take a photograph. But this is kind of a, kind of your scheme of how to deal with hypoxic respiratory failure. And it makes a lot of sense, and it's very simple. We're not going to have this where somebody's high altitude to where they're not even breathing in an adequate PO2. And it's not that these are what you need to think about to make a diagnosis. I mean, if somebody's got left heart failure and pulmonary edema, that's not a diagnosis you're going to make because they're hypoxic. There's going to be other stuff going around. The ones that you've got to kind of think about that'll sneak up on you, and are usually pretty dramatic and easy to find, are pulmonary embolus or fat embolus after some femur fractures or something like that. But these are kind of things, and if you look at this, alveolar filling is how they describe it, so that makes it kind of easy to kind of remember things in this group. It's filled with water. It's filled with water. Filled with water. Acute lung injury, ARDS, is really a pulmonary edema. So anything that kind of occupies the alveoli so that the gas can't get across, okay? And this one is the one for hypercapnic respiratory failure. And this, remember what they call it, the respiratory pump or the ventilatory pump. So this is motion of the chest in general, okay? You can't get the gases to exchange, but they're all kind of motor problems, okay? Drug effect, they're too sedated. They've had some sort of stroke to where they're not breathing. The only ones that are kind of intrinsic lung disease are in both columns. COPD, asthma, cystic fibrosis, pulmonary fibrosis, and pulmonary edema. These are in both. So you can have a combined respiratory failure of hypercapnia and hypoxia. But remember, hypercapnia is you can't get the CO2 in and out. So it's muscular kind of stuff, okay? All right. Hypoxia is at the tissue level, and so your SAT is out distally on your finger, so that kind of helps it. But there's a hypoxic hypoxia as you're kind of thinking about how this is happening. We're not providing enough oxygen. Maybe you just need to supplement oxygen. My trauma faculty called anemia, you didn't have enough boxcars to carry the hemoglobin to carry the oxygen, so maybe they need some blood. Circulatory hypoxia is the heart's not pumping enough to get the circulation out to the distal tissue, so it's having to extract more. So you can compensate for that for a little while, but you may have to do some dobutamine or something like that to help the pump, the heart pump. And then there's a histologic hypoxia, which is just a poisoning. Carbon monoxide kind of goes in this, but really that's a problem with the hemoglobin. So you can kind of think of it that way, but the treatment for that is oxygen, which hopefully you're already doing. Cyanide, you've got to do other stuff. So those are your kind of processes, okay? Acute lung injury, ARDS. The gist of this is it's a pulmonary edema, okay? It may be the alveoli is filled with fluid initially, kind of interstitial, transudate kind of stuff. If you get an infection on top of that, the alveoli is occupied with pus, inflammatory cells. So it's a life-threatening inflammatory response in the lungs that is a non-cardiogenic pulmonary edema, all right? That by itself is a 35 to 40% mortality, which our last lecture we talked about per organ system that fails, that's about a 25% mortality. This is not an isolated process, so this is secondary to something else. So really this is, kind of whatever else is already wrong plus another organ failure, so you're getting up there, 40, 50%, something like that. So the appropriate clinical setting, they've got some other process going on that tipped them over into acute lung injury. Acute onset of bilateral infiltrates. Your ratio is less than 300, and there's no evidence of a cardiac reason for this pulmonary edema, okay? For the students, real quick, chest x-rays, just kind of bilateral. Some people say cannonballs, cotton balls, or something like that. Ground glass appearance. This looks more like ground glass to me. You can see it's bilateral. It's not a distinct wedge like in a pneumonia or a PE or something like that. And so really the only good parts of this lung that are ventilating are kind of these peripheral edges out here. All right. All right, number one cause, always sepsis, kind of in keeping tune with my lectures. And then there are direct injuries to the lung. Pneumonia, aspiration is a chemical pneumonitis, chest trauma where there's actual contusions of the lungs, near drowning where the lungs are filled with water, or some inhalation that sparks an inflammatory process. Transfusions cause acute lung injury just by volume themselves, or then there are little immunofactors that can be injurious too. Okay, pancreatitis and burns are always in here too. Those are kind of the two, not septic, but surgical processes that end up in these sections. All right, so 3 predictable phases. The first one is kind of the injury phase, about the first week or so. and just everything's wrong. The lungs are filled with water, proteins, neutrophils, and the alveolar spaces are just filled. So you can't oxygenate because you can't get the oxygen across. In the second and third weeks, if they don't die in the first week, you start kind of getting better. And so the type 2 pneumocytes become more numerous, so they're able to create the surfactant to help the alveoli be able to expand and get some of that crap out of them. And so the edema's getting better, and as that's getting better, your gas exchange is better. And beyond 3 weeks, hopefully they're better, but that's a period of scarring and fibrosis. Everybody will have some component of that, but you just don't know how much. Every patient's different, so some will end up with long-term trachs, long-term LTAC-As, trying to get them through this, okay? So it's about, kind of a week. All right, so treatment strategy. Everything in the ICU is supportive care. If you want to use low tidal volumes, about 6 cc's per kilo, 5 or 6, something like that. I think standards here about 5. I mean, not that long ago when I was a resident, we used 10. That's just outrageous now. You would never do that. So you don't want to be providing too much pressure, causing barotrauma to the lungs, and you're going to allow the alveoli to kind of sit quietly and get better. PEEP is going to increase your aeration by putting a little pressure in your vent circuit and kind of driving the oxygen across kind of those marginal alveoli, and it's going to pop open atelectasis, okay? When you increase your PEEP, you likely can decrease your FiO2. But you got to be careful. I've all certainly seen this. When you go higher and higher on your PEEP, you're interfering with cardiac filling, so you can cause some decrease in your cardiac output. So treat everything you can, low lung volumes, PEEP that you can tolerate, try to get your FiO2 down, and treat everything else, Treat the pneumonia, the abdominal sepsis, the whatever else is going on. Wait it out. This is not one that you're going to really push on the vent, certainly at the start. Steroids, again, we don't like those. We talked about them last week, using them when you've got an adrenal crisis, where you've got them volume resuscitated, maybe you're on some pressors and you're still not able to have an acceptable blood pressure. You would use steroids. This you're going to use prednisone for about 2 weeks. All right, so we'll get off of that one. I'll send you all these too to study, in the week before the test. Acute kidney injury, definition is acute loss of kidney function. Thank you. Thank you very much. And so the more discrete definition is a rise of creatinine of 0.3 in 48 hours. See that all the time, don't we? Just give them a little fluid and it goes back down, please God, please God. Or a 50% increase in the 7 days. And this, you see this all the time on the floor. We see it in the unit. It can happen, pretty quick where everything's kind of going along, and then you notice that their creatinine's gone from 0.8 to 1.1, 0.2, which is still, fairly normal, but that's a pretty big change. So be kind of in tune to even subtle changes like that. And it may be somebody's eating and drinking, but they've got a big wound, or they're just not eating and drinking like they should, or there's still some inflammatory process going on. So, be careful with your fluids. And again, you have to think of our patients. Probably his heart's not so good, probably some hypertension and all this stuff. So it'd be easy if only one thing were going on. So the 3 components or the 3 possibilities are pre-renal, something intrinsic in the kidney, or post, where there's something obstructive. And so pre is a volume problem. There's not enough flow to the kidneys. So the kidneys, the renal vessels vasoconstrict. The kidneys perceive that as low volume. They hang on to sodium, which can then kind of snowball you down toward a renal problem. So renal is something intrinsic to the kidneys, obstructive, BPH, something like that. Obstructive Foley, hopefully you'd realize that before they got to where they were actually in renal failure. So what you want to look for is reversible cause. Always, hopefully, it's just hypovolemia. A little more fluid and everything gets better. Third spacing causes hypovolemia. A bad pancreatitis is going to be running kind of dry. And, you don't want a balance of everything. If you got somebody that's hypovolemic and you're trying to give them fluid, well, then you dump them into pulmonary edema because their hearts are bad. So careful hydration. Obstruction's easy to fix. Hyperkalemia is kind of the problem. That's what will kill you quickly in acute renal failure. Be careful with volume overload. Volume overload can precipitate congestive heart failure, which, even though they're volume high, they're actually intravascularly volume dry. This is rifle criteria. This is cute. There are all these little things. And I don't know that this is so much testable knowledge here, but this can kind of tell you how far down this funnel you've gone. But you follow the creatinine, so it's 1.5, 2, 3, or an absolute creatinine greater than 4. And these are the urine output criteria. I mean, this is minimal urine output, 0.5 cc's per kilo per hour. So if they drop below that for 6 hours, they're already at risk. So hopefully a little bit of fluid, and that'll get fixed. Injury, when that's prolonged, you know, it's just kind of the bomb's ticking here until you end up down here where you're not making any urine. And the definition of acute kidney loss or persistent acute renal failure is when you've had complete loss for 4 weeks. Hopefully when you get that far, you don't progress here. And in general, if they had normal renal function before and they've had whatever insult or acute illness, if you can support them and they don't die of something else in between, this will come back. I mean, we see this in burns with rhabdomyolysis after a big electrical injury. Kidneys will just stop. I mean, nothing for weeks. And the nephrologists are like, don't worry about it, it'll come back. Don't worry about it, and you're freaking out because you've got this big burn and dialysis and lines and all that. And they just come back, okay? So in general, if you were normal before whatever happened, it'll come back. So hypovolemia, you want to ideally not have that at all, but if you do, you're going to bolus them with fluids carefully. Recommended normal saline. Again, hopefully this person's in the unit or got adequate monitoring where you can do it. You may just have to give them a liter on the floor if they're kind of a normal patient otherwise, young and healthy, that came in with a bowel obstruction or an injury or something like that. And they've got a normal heart and a young, healthy patient, you can be a little more generous with this. But if I have to do this, most likely my patient's in the unit, and I love a flow track, right? It's the easiest thing in the world. Just an A-line and do that. And we use albumin all the time, probably not very judiciously. There's no real benefit to it. We'll give that sometimes when you've given a lot of saline. You know, I know this stuff's just going in his lungs. We'll give a little bit of albumin to try to keep some of it in the vascular space. That's just, honestly, we shouldn't do that. It's not proven to work. It's expensive. And so those who don't respond to fluid with an increase in urine output already likely have some component of ATN established. So ATN is a tubular problem, and the gist of that is they can't retain sodium and concentrate the urine. So you're probably not going to find this single event. Most likely it's prolonged pre-renal state along with some of these other interventions that we have to do, or the insult. Myoglobin and myoglobin, the way it causes renal failure is it actually precipitates in the tubule. So it's almost like a post-obstructive kind of process. And so when they're clotted with these crystals, you just kind of wait it out, and as they slowly dissolve, you'll get renal function back. So what you'll see in ATN is, I never think about getting this. In a pre-renal state, the fractional excretion of sodium should be low. The kidneys are seeing low volume. It's trying to retain sodium and hang on to fluid, so that would be low. Here, the kidney can't do that, so the sodium's going to be high in the urine. So that, you know, if you're taking diuretics or giving them diuretics, that's not going to be accurate. So you'll see the nephrologist will try to draw that first and then give their diuretics and try that way. They may have to be supported with some sort of dialysis. It may take months. You know, everything the nephrologist writes in their plan, avoid nephrotoxic drugs, renal dosing of medications. And if they had normal renal function before, whatever insult, 90% will come back. I've seen this on the website back when I had to take it. Indications for dialysis, you know, we don't really think about these. This is the one we usually kind of think of, volume overload, where we've pushed them into pulmonary edema and your diuretics won't get it out. Hyperkalemia, we'll talk about that in a second. That is a true emergency. Metabolic acidosis. This is not really going to be something that's acute, but this is a reason that to kind of continue dialysis, or how nephrologists will kind of say, no dialysis today, you know, we'll dialysis in tomorrow. And uremic symptoms. Hyperkalemia, you'll get called for an abnormal lab value. A lot of times around here it's just a lab abnormality where it's hemolyzed or whatever, and it's abnormal. If everything's been fine and normal renal function and everything, the patient's fine, you can repeat it. But higher than 6.5, I mean, we're saying routinely they're 5.7, 5.8, something like that. But when it's up here, this is an emergency because it causes cardiac arrest. Okay, not much you can do about that. And so if you see that, you want to you got to treat it quickly. But you'll see these in catabolic patients, patients with multiple injuries, very sick, where they're metabolizing their own protein, rhabdomyolysis. In addition to causing renal failure, you've got cellular debris spilling over into the vascular space. And it may be as simple as, they got some potassium in a fluid or some kind of other medication or something like that. Sometimes these are kind of hidden. And they'll actually be in the pop-ups that pop up on every single order you put in, right? And you just go skip or whatever it is, whatever the button is. But be careful if you've got somebody with hyperkalemia or some renal failure. Pay a little bit more attention to those pop-ups because some of these antibiotics have potassium in them. Okay? Treatment for hyperkalemic emergency, calcium gluconate to protect the myocardium. Give all three, bicarb, insulin, and glucose to push the potassium into the cells. Diuretics are going to take a little bit longer, but if they're putting out urine, that can dump some potassium because Lasix, remember Lasix, you lose everything, all your electrolytes. And you want to, if you can give some K-oxalate or something like that to bind any that's in the GI tract so you don't absorb anymore and you can get rid of what's in the body already. Okay? That'll probably be on the test in some way. This is from the score, directly from the modules, and so it's just your list. It's pretty simple if you just kind of think about it, but it's good to look at. Inflow pre-renal is going to be volume at the start, something intrinsically wrong with the kidney. Outflow, crystals would be your myoglobin, hemoglobin, and of course BPH and stuff like that. Contrast-induced nephropathy, certainly if you order a CT on somebody that doesn't have normal renal function by now. And, of course, you pre-treat with fluids and some N-acetylcysteine. I'm not really sure of that mechanism, but it's kind of just a knee-jerk reaction. And you'll see a rising creatinine after somebody's had IV contrast. But the deal of it is there is a renal vasoconstriction as a result of IV contrast. So your fractional excretion of sodium, if you check that urine, will be low. Okay, so the kidneys perceive a low volume. Okay. All right, last section, last organ. Hepatic failure, we're not going to talk about somebody that's got like kind of chronic liver disease, viral hepatitis or something like that. And again, these are not diseases we treat. These are medical illnesses, and sometimes we have to deal with them emergently with other surgical problems, but this is just kind of, these are not managed by us. These should be managed by the transplant hepatologist. So acute liver failure, the discrete definition of that is encephalopathy and a coagulopathy that is kind of acute, like they didn't have it 6 months ago. That seems like a long time. But it's a patient without cirrhosis or a patient with cirrhosis who has kind of slid down a little bit more. But, of course, untreated, it's an organ failure, poor prognosis. About 40% will require a transplant. Some will get better on their own. I didn't realize this, but far and away, the number one is acetaminophen, 40%. Hepatitis B, hepatitis A can cause this, but hepatitis A is a much more kind of self-limited acute illness. Drug reactions, and of course unknown, but a lot of these unknowns are actually acetaminophen. And then these other ones, okay? So Tylenol, number one. So if you don't know, you treat for Tylenol toxicity. Some of them are not as bad as others. If you got to have one, I guess the one to have is acetaminophen toxicity. Hepatitis A is an acute, somewhat self-limited hepatitis. Ischemic liver injury, correct that with fluids. Pregnancy, you deliver. So if you got to have one, take one of those. About 50% will not require a transplant. And the worst prognoses are things that you just can't do anything about. Wilson's disease, copper's unavoidable. And so these end up with transplants, okay? Treat the underlying cause. N-acetylcysteine. And actually, in reading about this, they all get N-acetylcysteine because sometimes you don't know, and it's, the toxicity of it is like nausea and vomiting. So it might actually help. So why not give it? It's cheap and easy. Just dump it down the NG tube. Hepatitis B vaccine probably doesn't have a lot of benefit. Mushroom poisoning, I don't know that we'll ever see that here, maybe. You get some charcoal, Bud Chiari, some kind of decompressive something. Wilson's disease, they temporize them with plasma exchange to remove some of the copper, but they're going to need up transplanting. Autoimmune hepatitis. These are patients, as far as surgery, we'll see them kind of down the road. Along with their autoimmune disease, it seems a lot of them develop gallstones. And it may be just they're in the 20 or 30% of the population is going to get gallstones anyway. But I've seen more than one patient in my clinic that had, lupus and a hepatitis with that. Now they've got gallstones that they attributed to the steroids and sent them for surgery. So that's kind of our role in that, I guess. And acute fatty liver or pregnancy, get them through and deliver them, and the liver will get better. Acetaminophen ingestion, again, we don't see this. I guess if you moonlight in an ER or something like that, you would see it. But an ingestion of greater than 10 grams per day. We try to limit with the pharmacy 4 grams per day. So that's a very low, kind of low end in what we allow. But 10 grams a day sounds like a lot, but that's 20 extra strength pills. So if somebody was really into it and trying to hurt themselves, that wouldn't be that hard to do. Or 150 milligrams per kilogram single dose. Or you'll see kind of a toxicity and a change in the liver enzymes if somebody's taking it for, a toothache or orthopedic something, or just kind of taking a sustained dose for several days. So if you're working in an ER and you know that they took it in the last 4 hours, you want to give charcoal and your N-acetylcysteine. You don't want to give them Ipecac. It doesn't get it rid of as much. But charcoal is going to go downstream some more and absorb it. Okay? And I didn't remember what N-acetylcysteine does. Again, this is not what we treat. Remember, it forms glutathione. I remembered that word when I read it. And what that does is it binds the Tylenol, so it's not in the circulation. It takes it out. And what Tylenol does to the cells is a direct toxic effect on the liver. So it kills liver cells is what it does. Okay? All right, so 10 grams a day, 20 pills. So again, this is one of those things, if you wait it out, hopefully the body will correct it. That's what Dr. McDonald told us about ICU patients. If you don't let them die, most of them will make themselves better. He said they're like cats. Okay? Don't let them die and they'll make themselves better. But you just kind of watch them. You're going to follow your trends of your INR and your bilirubin. Those absolute numbers may not mean anything specifically, but the trend is very important. Maybe they're getting better, maybe they're getting worse. If the bilirubin goes down, maybe they're getting better, or it could be there's so much loss of hepatocytes that they're not even spilling bilirubin anymore. So just the initial trend may be hard to kind of decide if things are going better or not. So you just follow your labs, follow your glucose. You're probably going to have to supplement glucose because the sick liver is not able to metabolize glycogen. You're going to have to support them like that. This is somebody you're not going to be feeding. So you're going to have to support their heart and brain with glucose. And so kind of the general pathophysiology of it is a low systemic vascular resistance. And so you've got to carefully hydrate them up. And it's just like sepsis. You may need pressors once you get your volume up, and they may also have an adrenal insufficiency, so you may need some steroids. And again, N-acetylcysteine probably won't hurt them, and it might help, so go ahead and give that too. And like we said, 15% or whatever, we don't know what the cause is. So maybe there is some Tylenol in there, and that can help. In general, you're not going to give prophylactic FFP because then you can't follow your INR trend. It seems wrong to just be sitting there watching the INR get worse and worse and worse, just letting them die before your eyes. But maybe they'll end up on the transplant list. By giving them FFP, you could push them into volume overload. But you may need it for procedures. And you may need platelets for procedures. So, have it running as a drip when you've got to do something invasive. And then after that, you just kind of let it go. Okay? Protect their stomach, PPIs, monitor for infection. So any acute worsening, it's probably an infection. So routine pan cultures every 24 to 48 hours. Watch the chest x-ray looking for an infiltrate. fungal cultures if they've been on antibiotics. So if there's any change, you want to kind of pan culture and think in that way. Encephalopathy is the decreased mental status. So that's the other component. And it's a byproduct of the gut bacteria producing ammonia. You got to be careful. Ideally these people aren't getting a lot of protein because that turns into ammonia. It's protein that's metabolized. But you've got to provide a source because the body's going to get its source. It's either going to catabolize its own muscle, or you can provide kind of a low dose in their GI tract so that doesn't happen so much. So maybe a gram per kilogram per day, 60, something like that, 70. Lactulose, we use it all the time in chronic liver injury, liver disease, but it may not have enough of a rapid effect in an acute encephalopathic person. But a lot of people will get it. They're ICU sick. You're going to have them on some kind of bowel regimen and something. Lactulose can kind of be a twofer. So it's not that helpful in an acute liver failure. Of course, there are grades to it. Obviously, grade 4 is the worst. That's coma, unresponsive, kind of end stage. Grade 3 is not quite as bad. Marked confusion, stuporous, sleeping but arousal. Grade 2 is probably an ICU or at least an in-the-hospital kind of person. They're lethargic and confused but can kind of speak to you and be okay. And grade 1 is probably somebody that's out and about. Maybe there's a little bit of confusion, sleep disorder, a little slurred speech or something. So obviously grade 3 and 4 are the bad ones. Cerebral edema is what kills people with acute liver failure. You always think about bleeding. But bleeding you can maybe do something about. You can fix that. If you've got somebody that's encephalopathic at stage 3 or 4, herniation happens just instantaneously. It's pretty quick, and there's not much you can do about that. So we'll run through the treatment of that that stage. But it's the number 1 cause of acute liver failure deaths is herniation from cerebral edema, 80%. So that's easy to remember. These are just like head injuries that herniate too. You have the Cushing's triad of hypertension, bradycardia, and irregular respirations. Same treatment as like a trauma. Minimize their stimulation and agitation, elevate the head of the bed, optimize your fluid balance, and hypertonic saline and mannitol. King's College criteria for liver transplant. We got 5 minutes. That's just a list. And remember that, again, acetaminophen is kind of the better one to have. Whoop, I'm sorry. I want to get down to Hepatorenal Syndrome since I'm about out of time. MELD scores, the deal with the MELD score is it looks at 2 organs, okay? Bilirubin and creatinine. It is a marker of mortality in the next 3 months if nothing happens to them. If the only thing you've got going on is this liver injury. So, we'll see people in general surgery clinic that's got some kind of something going on, cirrhosis or something like that. And you get a MELD score of like 12. That's not that big of a deal if somebody's got a lipoma on their back or, an inguinal hernia or something like that. So the bigger marker of mortality in somebody with acute liver failure that's like in the ICU dying sick is all the other organ failures. Your MELD score doesn't help you so much in that setting, okay? So the MELD score is more for somebody that's kind of up and about and doing their thing, okay? Okay, hepatorenal syndrome. Now this I didn't know nothing about. I know it's bad. And so I'm really having trouble putting all this together, and I'll tell y'all kind of the 3 pieces I put together on this, studying up on it in the last week, because this was like one of the specific things in SCORE to know. The way I think of it is you've already got 1 organ failure, and now you've got another one. So, of course, poor prognosis. But the patients that get this is somebody that's cirrhotic with ascites from whatever cause. And then they start developing a rising creatinine, and the urine output at the start is kind of okay, and it'll taper off. But what it is despite being maybe volume high with ascites and such, they're intravascularly volume low. Okay, so the kidneys perceive that as volume low, and so they retain sodium. Okay? And so it pushes you into kind of a pre-renal state that's somewhat irreversible. You can try fluids and such, but it's really hard to come out of this. Okay, so you may end up supporting them with dialysis. Maybe they'll get better, maybe they'll need a transplant. But it by itself has a 21-day median survival. So they're either going to get transplanted or they're probably going to die. So if you see this, you can think of it as another organ failure, but the gist of it is somebody that's got cirrhosis, their creatinine's going up, and the low urine sodium is what it is. Okay? This will be one question. Answer C and move along. This is whatever. Okay, so this is my last slide. You got type 1, which is the bad one. The creatinine doubles in one of those brief intervals, or it rises to 2.5 over 2 weeks. And so they're going to die if you don't transplant them. Type 2, which is a little bit better but still pretty bad, is the ascites that you can't do anything with on diuretics. Okay? So most of these, when you start seeing the creatinine rise, are going to be a hypovolemia. Correct that with fluids, prerenal, and then kind of the remainder will be this hepatorenal. Okay? Again, that's one question every 2 or 3 years. All right? I'll send y'all these. Read them the week before the test, and you can probably get like 2 questions. Okay?